Hello and welcome to this lecture on necrotizing enterocolitis, where I will be talking about the long-term outcomes and correlations with later cognitive function, quality of life, and issues of major importance for the families of babies who have been affected by necrotizing enterocolitis. And as I've previously mentioned in my other lectures, feeding preterm infants is very much focused on improving outcomes, improving survival for these premature babies, but is also aware of the importance of trying to reduce disease, particularly necrotizing enterocolitis and other related disorders such as lung disease and retinopathy. We're interested in promoting adequate growth as a reliable marker of nutrition and nutrient intakes. As I say, very much focused on the long-term brain outcomes here, but also how all of the area of nutrition and growth relates to family issues and how we can ensure and promote parents' involvement in many aspects of nutrition and growth. And for neonatologists, many perceive that there may be some dilemma between how we can feed babies and ensure they grow whilst trying to avoid necrotizing enterocolitis. But I think it's possible that we can do both at the same time. And better nutrition is key to improve survival. Over the last 25 years, we've seen many improvements in several aspects of nutrition, particularly parenteral nutrition, improvements to knowledge about the benefits of breast milk, but also a lot of work looking at how we promote growth through the use of other supplements and fortifiers, and potentially the role of bionutrient supplementation. And as more and more babies survive, their nutritional needs become more important and more complex. And we're now looking after babies born at 22, 23 weeks and babies who have developed necrotizing enterocolitis who now survive. And so we need to really better understand how we meet their nutritional needs. And the challenge we face is to optimize survival and long-term outcomes, whilst at the same time avoiding disease. And optimizing growth is likely to have important benefits over the life course, both for brain development and metabolic outcome. And so how we feed babies in early life, particularly on the neonatal unit, is likely to impact lifelong on your risk of diseases such as osteoporosis, Alzheimer's and dementia, but also your risk of myocardial infarction and other adverse cardiovascular events. But in this lecture, I want to talk about the longer-term outcomes of necrotizing enterocolitis, which really is a terrible disease and continues to affect a significant number of babies on the neonatal unit. Now, necrotizing enterocolitis is an acute, life-threatening, multi-system inflammatory syndrome, and it involves inflammation and intestinal necrosis. But we should see this disease as the end result of multiple different processes and mechanisms. We know there are multiple risk factors. Many of these are to do with immune regulation. But although we understand many of the mechanisms and risks, the initiating event in most individual cases is never known. And we will see babies with risk factors, for example, very low birth weight babies, babies who've never had any mother's own milk, who never develop NEC. And it's difficult to understand why some babies develop NEC and others do not. Now, when we want to understand the longer term outcomes, this of course depends on the setting and the definitions of necrotizing enterocolitis. If we consider serious NEC, around about 50% of these babies are going to require surgery. And of these babies, around 50% sadly will die. And even in the babies who survive, there's evidence that many of them suffer multiple insults that will harm the developing brain. And in the lecture today, I want to discuss some of the mechanisms of brain injury, some of the longer term uncertainties, some of the parent perspectives, and how we can use nutrition and other related interventions to improve outcomes. Now, there is substantial uncertainty around why NEC occurs and what it means. And NEC really is a very cruel disease. We know that most babies born at 24 weeks gestation will develop bronchopulmonary dysplasia. And almost all of these babies will develop retinopathy of prematurity to some degree. But NEC is different. And when it occurs, we often ask ourselves, why did this baby develop NEC? Did I start the feeds too soon or too late? Should I have treated the patent duct? Did I increase the fees too quickly? Should I have started probiotics, maybe the fortifier course? We all come up with these many questions, but we rarely have answers in individual cases. And the lack of predictability and understanding can be heartbreaking for parents, because typically NEC occurs around about the 3rd week of life, where many parents have started to feel that their babies were through the worst of the neonatal experience. Now, there have been several studies looking at the longer term outcomes following NEC. And we know overall that there's a significantly higher chance of what we might call worse brain outcomes. But what do we mean by this? What do we mean by worse outcome or a bad outcome or a not normal outcome? We need more data. We need more data to guide clinical decisions. We need data to guide research of newer interventions. We need observational studies to better understand the risk factors. We need to conduct audit and quality improvement. But most importantly, we want to be able to better inform parents once NEC has occurred. Because this uncertainty about what it means and why it occurs is never ending for parents in their very long neonatal journeys. And I'd like to recognise the important work done by advocacy groups, particularly NEC UK and the NEC Society in the US. So if we just stop to think what it might be like to be a parent who's just been told that their extremely premature baby has developed neck enterocolitis, what sort of questions may they have? They're obviously going to be concerned about if he's going to survive the surgery and go home, what impact it might have on family life, what impact it might have on his siblings. In some societies, they may worry about whether they will be able to afford his care, whether they will be able to go back to work and resume their careers, whether the baby might need lifelong care and support, and even what will happen at school. What will his quality of life be? Will he have friends? So there are many questions that parents will have, and we will not be able to answer all of those at the stage that the baby first develops necrotizing enterocolitis. So we have got a lot of data from population studies, but extrapolating these outcomes from population data to the individual baby is challenging. And it's particularly problematic because of a lack of robust definitions. What do we mean when we say a baby has had necrotizing enterocolitis? Well, when a baby requires surgery and we can see necrotic bowel that is confirmed histologically as being classic of NEC, and there are classic risk factors, so the baby is extremely premature, well, that's easy to call this baby NEC. But in other cases, there may be less agreement. For example, a baby born at 25 weeks who on day 10 has patchy inflammation and ileal perforation. Maybe this was an intestinal perforation that wasn't picked up straight away and the baby developed peritonitis. What about a baby born at 27 weeks who on day 20 has some X-ray evidence of pneumatosis and the CRP increases a bit but otherwise remains systemically well and does not need surgery? Did this baby also have necrotizing enterocolitis? So necrotizing enterocolitis is a subjective diagnosis and the outcomes vary. And the lack of specific and sensitive tests combined with the lack of internationally agreed criteria for diagnosis means that the true outcome may be better or worse than is published in the large case series. So how do we extrapolate outcomes from the population of the individual baby? What is it that parents need to know? Well, it's not surprising that babies with the most extensive findings at laparotomy have the worst brain outcomes. But defining the degree of illness or severity is complex. Many people use the Bell's staging criteria, which gives you 3 different stages, with stage 2 broken down into 2A and 2B. And many studies therefore just include babies with stage 2 or greater NEC. However, Bell's criteria was never designed as a diagnostic or predictive value for NEC. It was really just used as a staging criteria to determine the safety of performing an operation and giving a general anesthetic. And the publications do not include this great detail, this granularity of the baby's illness. So we cannot extrapolate the outcomes to an individual baby. And it may not then really help parents very much to know that the group average outcome is whatever. Furthermore, NEC is an ever-changing disease. A baby at 28 weeks who developed NEC in 1995, it's possible that we can study them and know what their outcome is. But does the same results apply, say, to a baby born at 23 weeks in 2025? So it's going to be very difficult to predict the long-term outcome of necrotizing enterocolitis. How should we present this information to parents? Well, we should be compassionate and honest. And we should provide this information in stages. We shouldn't provide it all at once because that will become overwhelming. When parents are asked what they want, they've often said that they want us to make improvements and make the information more accessible, more personalized, and more practical. But importantly, parents ask us to be more positive. And it tends to be true that physicians tend to focus solely on the diseases and the bad outcomes. But parents say to us, don't just focus on the disease and the baby's disabilities. Try and help me and provide some hope. Try and help me with some positive messages about the future. So as clinicians, we do want to know the difference in outcome if a baby develops necrotizing enterocolitis. That's important to us. But generally, parents are not so interested in the outcome following necrotizing enterocolitis. They just want to know the outcome for their baby rather than the independent contribution of necrotizing enterocolitis. So what are the important long-term outcomes following NEC? Well, in all areas of medicine, there have been improvements because of the development and use of core outcome sets. And core outcome sets are developed through a consensus procedure involving multiple stakeholders using the Delphi method. And the outcomes are then endorsed by an informed panel that needs to include healthcare professionals and parents and individuals with lived experience themselves. And getting this information, particularly from hard-to-hear populations, can be challenging. So families that are affected by socioeconomic deprivation, have limited access to internet data or health literacy, may not contribute to these outcomes as much as other families. Delphi techniques are quite time-consuming to do, but many find that the final shortlist of outcomes can be quite challenging and may not reflect what they're truly interested in. So clinicians, parents, children, and young adults affected by NEC will all have a different perspective. As academics, we might rate cognitive outcome as being more important than motor outcome, but other people may see things differently. And parents generally are most interested in developmental trajectory as being more important than comparison to their peers. Parents want their child to have a fulfilling childhood, to make friends and join in school activities, because impairments may exclude them from friendship groups. And many children may see those with disabilities as being different. Disability may make childhood games difficult. And in adolescence, children may be more concerned with physical appearance and scars, problems like diarrhea, or they may have reproductive health concerns. So what matters most changes over time. But there has been some important work on developing core outcome sets following necrotizing enterocolitis that has involved multiple health professionals, parents, and young adults affected by this. And they came up with 5 key areas, which most of you can understand would have been included. So an outcome of mortality, particularly outcome related to the NEC itself, impacts on physiological and clinical functioning, such as short bowel syndrome, the lifelong impact of neurodevelopmental impairment, and important aspects of quality of life. So what damages the brain after necrotizing enterocolitis? Well, there are multiple mechanisms. Several factors associated with NEC also have an independent impact on brain development. So, for example, breast milk improves brain development independent of causing less necrotizing enterocolitis. What are the mechanisms involved in brain injury? Well, initially, we have oxidative stress, neuronal excitotoxicity, and apoptosis, and then very rapidly progressing to what people call a cytokine storm within a few hours. And these cytokines damages neurons, cells, and white matter, and disrupts the programmed development of brain structures, and also disrupts the connections between different parts of the brain, the so-called connectome. Cytokines released in the gut cross the blood-brain barrier, where they damage a variety of cells, including microglia, and they interfere with normal neuronal migration, which is occurring in the 2nd and 3rd trimesters. There may also be impacts on cardiorespiratory function and impaired cerebral autoregulation, which may affect oxygenation. So we can think of these as a schema, thinking about the things that occur in the first few minutes, such as oxidative stress, and hours, such as apoptosis. But then all of the damage that occurs to brain structures over the next few hours and days, and even when the baby starts to get better, we still see adverse effects from the impacts of malnutrition, adverse impacts on the gut-brain axis, neurotransmitters, and later life outcomes. So this is a very complex, long, multi-system disorder whereby the damage to the brain is going to be very complex indeed. I want to highlight the importance of the gut-brain axis because this not only is associated with the development of NEC, but also the longer-term impacts. And NEC is likely then to also result in dysbiosis. That's because the babies are not being fed milk, so the bacteria that grow in the gut are going to change. And the gut microbiome will also be adversely affected by the antibiotics we give them and potentially other drugs. And so we call all of this the gut-brain axis, the interaction between the nervous system in the gut, the so-called enteric nervous system, which includes trillions of nerves, and the interaction with the central nervous system here. And we know that this is very important through a lot of work over the last 10 or 20 years. And there are relationships then between what happens in the gut and what happens in the brain. So in the gut, we might think of disorders affecting motility, bowel habit, weight gain, and these may be related to psychological symptoms such as your mood, behavior, anxiety, and stress. And all of this is modulated through the enteric nervous system and a range of peptides and other hormones. And so we can measure some of this by looking at the pattern of bacteria, the levels of cytokines, peptides, short-chain fatty acids. And this has been increasingly studied over the last 10 or 20 years and represents an interaction of multiple organ systems and pathways involving, as I say, hundreds and thousands of metabolites, cells, hormones, and nerves. And if you want to get an idea of how profound this might be, there's some very interesting data that has looked at this in relation to Parkinson's disease, a very well-known neurological disease in later life. And when they've looked at it in people with Parkinson's disease, they've noted that people who develop Parkinson's disease going back have a history, a very consistent history of constipation that occurred more than 10 years before they developed Parkinson's disease. So very strong evidence that the gut-brain axis is profoundly important on brain function. So necrotizing enterocolitis is caused by and causes disturbances to the gut-brain axis. There are multiple pathways, many of which we don't understand in preterm babies, that may involve inflammatory and other small molecules such as short-chain fatty acids, hormones, microbial products, neurotransmitters such as serotonin, GABA, and tryptophan. That's likely to have a significant impact on brain metabolism and may indeed reprogram long-term brain function. So, necrotizing enterocolitis is a complex multi-system disease. There are many causes, including the gut-brain axis. These immune and inflammatory pathways impact on brain development, and the damaged brain cells and connections may have lifelong impacts, including disorders of development. Parent and clinician uncertainty exists on multiple levels. Outcomes are very complex, significant, but also very individual. The diagnosis of NEC is not robust, and core outcome sets have been developed. So we really now want to try and better understand what happens to a brain when a baby gets NEC. Well, in the early acute phase, as I've said, cytokines will damage the brain cells and connections, but this may be made worse by hypoxia, ischemia, septicemia, and coagulopathy, which often occur in a severely sick infants. We know the levels of certain cytokines are correlated with later cognitive and psychomotor functions, such as interleukin-6, suggesting that the duration and intensity of the inflammatory response affects later outcomes. There's evidence that general anesthesia may pose a risk to the developing brain, and many of these babies are going to need other drugs, such as antibiotics and inotropes. And it seems likely that many of the excipients or toxins associated with some of these drugs may themselves have adverse effects. And this may be compounds, preservatives such as benzyl alcohols, ethanols, and propylene glycol. We know that these babies need high energy, but they also produce a lot of endogenous catecholamines and they develop insulin resistance. So many of these babies become hyperglycemic, hyperlipidemic, and have electrolyte disturbances. It also seems likely that excess nutrient intakes during this period of critical illness may overload cellular autophagy. So autophagy is the body's digestion of proteins and peptides. An impaired autophagy disrupts normal cellular metabolism, and this may further worsen cardiorespiratory and brain function. So the biochemical response in all babies or in everybody to stress is an increase in production of catecholamines, glucagon, and cortisol. This causes increased endogenous glucose production, results in peripheral insulin resistance, and therefore you commonly see the glucose level go up. But catecholamines and glucagon will also result in fat breakdown, lipolysis, and protein breakdown. And this results in high levels of free amino acids and free fatty acids. And again, biochemically, you'll see raised triglycerides and a reduction in low and high density lipoproteins. So the biochemical response in the first acute phase is quite complex. After the first few days, so-called later acute phase, babies fail to tolerate or receive or even assimilate nutrients. They can't make new lean tissue. And because they don't get milk, they also don't get these beneficial breast milk components. They don't get phospholipids and nucleotides and oligosaccharides and IGF-1 because we put them nil by mouth. We give them parenteral nutrition, which is life-saving, but itself is associated with increased risks of sepsis. It also results in higher intakes of aluminium. We shouldn't be giving the babies any aluminium, but necessarily, unfortunately, glass becomes contaminated. And manganese, which also contaminates many parenteral nutrition solutions. So if you look in the MRIs of babies who've had a lot of parenteral nutrition, you can see these deposits, manganese deposits in the brain. Intravenous lipid is, again, life-saving, but results in abnormal fatty acid profiles. And both excess and inadequate intakes of amino acids may also be harmful. Necrotizing enterocolitis is a painful disease, and pain itself may damage the developing brain, particularly areas such as the amygdala, cingulate gyrus, and thalamus. During the recovery phase on the neonatal intensive care, babies may not be receiving kangaroo mother care. We know that kangaroo mother care is good for the brain, but this is challenging if the baby is sick. Re-establishing motility and feed tolerance takes time. Babies need to upregulate digestive and absorptive capacity. And they need to transition from the acute stress catabolic environment to an anabolic hormonal milieu. And this may take several days. Babies who have a stoma may absorb less and lose more nutrients, particularly all of your macronutrients, electrolytes, and your vitamins and trace elements. The NICU environment is abnormal from a sensory perspective. So babies have an abnormal experience relating to sound, light, touch, and comfort holding, all of which may harm the brain. Some babies may develop liver disease in association with parenteral nutrition. And for many, successful oral nipple feeding or direct breastfeeding is never achieved, something else which may impact on brain development. And then in the post-discharge period, we understand the importance of avoiding or minimizing the risk of growth failure, which may further worsen brain outcome. Babies might be at risk of micronutrient deficiencies such as iron, and we need to promote breast milk because this may continue to provide beneficial components of the brain such as stem cells, milk fat globule membrane, and human milk oligosaccharides. Early infancy is a critical time for the development of social networks. Caregiver approaches during this period impact on feeding behaviors throughout life. And also the experience of babies who've been critically unwell, particularly those with necrotizing enterocolitis and those with other nutritional issues, may have adverse impacts on speech and social communication development. And this is even more complex in babies who have short bowel syndrome. And there's very good evidence showing that short bowel syndrome infants have lower cognitive, language, motor, and growth development. Does growth matter? Well, growth is more than weight gain, as I've told you in previous lectures. Growth includes thinking about length, head, and body composition. We need to plot this on an appropriate growth chart and recognize that weight gain is not the most important outcome, but weight gain is important to measure because it is a reliable marker generally of nutrient intakes. If weight gain is slow, this may be a marker that you're not providing sufficient nutrients for optimal brain growth. But again, remember that breast milk bionutrients are vital here if we can get them into the baby, and breast milk nutrients are probably more important than weight gain on its own. So we can put all this together and consider what we call the exposome of babies who develop necrotizing enterocolitis. The exposome represents the totality of exposures. So throughout the whole of this experience, the babies may be suffering from an abnormal sensory environment, a lack of kangaroo care, lack of mother-infant closeness. There are lots of different mechanisms in the early acute phase, in the later acute phase, and impairment of nutrients and growth, suboptimal fatty acid and amino acid intakes. We've talked about all of the toxic exposures, the risks of PN-associated liver disease, impairment to gastrointestinal tolerance, digestion, transit, and absorption. And then in the post-discharge period, the risks of poor nutritional status and growth and micronutrient deficiencies. And all of these exposures here may disrupt normal development and may result in the adverse neurodevelopmental outcomes that we see in babies who develop NEC. I just want to think about our language here when we're talking about the outcomes. NEC impacts on a range of brain development, affecting cognitive, sociobehavioral, language, sensory, and motor domains. Impairment is the loss or abnormality of psychological, physiological, or anatomical structure or function as defined by the WHO in 1980. That's what impairment is. Disability is the impact of this impairment. an impairment that restricts or results in a lack of ability to do the things you would expect for that individual. So, for example, as a child, a lack of ability to play games. Hearing impairment, which is fully correctable with hearing aids, is not considered a disability. It's an impairment, but we're able to correct for this. And handicap is the disadvantage that limits or prevents fulfillment of a role that is normal. So for a baby or child who has cerebral palsy requiring a wheelchair with adequate modifications and support that enables full participation in school, a child with a disability may not consider this to be a handicap. Now, when I was researching this, I found these F words described by Rosenbaum. So impairment is difficult to measure. We know that neurodevelopmental outcomes are multidimensional and non-linear. And although many people do the Bailey scale at 2 years of age, this is not an accurate predictor of function in later life. So studies of neck transient colitis looking at childhood outcomes, brain outcomes need to be more robustly assessed. And these take time, they're very expensive, and studies suffer from a lot of attrition. And this limits their validity and generalizability. We know that socio-behavioral and communication outcomes are important, and these may impact on quality of life. But again, this is very difficult to assess before school time. So just thinking a bit more about these F words that I think help us think through what NEC might be. The F words are function, i.e. the activity of that child, fitness, the body function of that child, family and the environment, friends and participation, fun and personal development, and future outcomes throughout the life course. So these 6 F words here, I think, quite helpful to keep in mind when we're thinking about outcomes for babies. So what are the actual outcomes that have been documented in research studies? Well, many of these, as I said before, are affected by the severity and duration of the inflammatory cytokine response. And it's not surprising that greater exposures to parenteral nutrition, lack of breast milk, antibiotics, and sepsis are likely to be associated with worse outcomes. There have been large systemic reviews of NEC cohorts that have been published recently, looking at studies from global settings, but only high resource settings. And what they show is that overall intestinal failure rates are around about affected in about a quarter of infants. Mortality rates of about 1/3 in those requiring surgery, but increasing to about 50% in the babies born weighing less than 1,000 grams. Significant neurodevelopmental impairment is described in about half of survivors, but with a very large range. But many of these studies have inconsistent definitions of neck transient colitis, intestinal failure, and neurodevelopmental impairment, which makes meta-analysis challenging. I'm going to show you some data from individual trials. This first set of data comes from a large trial conducted in the UK, the so-called Oracle trial. And this trial included a randomized controlled trial of pregnant women with preterm premature rupture of the membranes. And women were randomized to different antenatal antibiotic regimes. But importantly, what they saw in this study was higher rates of neck transient colitis in the group receiving coamoxiclav. And they were able to follow up this group of babies and see what happened. Now, 25% of the infants who developed NEC died. At 7 years of age, those with NEC were more likely to be impaired, although there was no difference in severe impairment in this study. But ADHD, attention deficit hyperactivity disorder, did appear to be more common in infants developing NEC. And they also had high rates of bowel problems at 7 years of age. And these bowel problems included constipation, diarrhea, and what were described as stomach troubles at 7 years of age. There have been many other large network studies, and a German network study looking at the outcomes of surgical neck transient colitis at 5 years of age. Weight gain was the same at 5, but head circumference and length was lower, and the adjusted risk of a low IQ was much greater, 3 times more likely. The Danish registry questionnaire-based follow-up study of neck transient colitis showed an abnormal social development in 24% of the babies compared to gestational matched controls, and higher rates of cerebral palsy. In a US study of infants born very premature, 22 to 26 weeks gestation at 2 years of age, the risk of moderate to severe neurodevelopmental impairment was much higher in infants who had short bowel, with high rates in both groups. And although I'm talking about necrotizing enterocolitis today, focal intestinal perforation is a different disorder or different disease. It's quite different from NEC. However, it's also associated with worse outcomes. So in a Dutch study of premature infants with focal intestinal perforation, 21% of these infants died, so almost as high as those with severe NEC, and up to 20% had hydrocephalus at discharge. And at 13 years of age, on average, median age of 13, so they followed up these infants for a long time. Almost 2/3 of them, compared to just 40%, had a disability. So focal intestinal perforation, like necrotizing enterocolitis, has lifelong impairment. This is a very important study from the NEC Society and many other academics, including data from about 200 families. Now, 72% of the parents who took part in the study reported ongoing childhood complications. And 90% of the young adults who took part in this reported issues relating to health-related quality of life. But when they were asked, most of them said that they were not informed or not helped to understand what had actually happened to them as a baby. And overall, only 25% of parents felt that their healthcare provider understood what had happened to them on the neonatal unit. Young adult survivors describe living with a body post necrotizing enterocolitis. They describe different relationships with food and eating, a change in body image over time, the development of problems that were not apparent in early childhood, impacts on bowel habit, their fear of intestinal adhesions in later life, and concerns about impact on fertility and flare-ups. And they said that most healthcare providers simply don't understand the adult implications of necrotizing enterocolitis. They also connected free text responses, and they did a content analysis here, and they could group this into 5 areas. So problems affecting gastrointestinal function and short bowel, issues around scars and self-image, social concerns, anxiety and depression, and ongoing access to care. So these 5 areas were the major themes that came out of this research. So how can we make things better for the babies? Well, interventions that may improve longer-term brain outcome. The first one here, I say, is mother's own milk. Mother's own milk, as I've said in previous lectures, is associated with numerous advantages. But there's actually no data to show that donor human milk improves outcomes. So no studies post-NEC, but in other preterm infants, no evidence that donor milk improves brain outcome. It's mother's own milk that we need to support. So we need to find interventions to encourage and support mothers to continue expressing milk during the acute phase of necrotizing enterocolitis. Just imagine how difficult that must be when you've provided your baby with your own breast milk, yet they still develop NEC, and then they're very sick, and then they can't be given milk. How challenging must it be to keep on providing express breast milk at that stage, particularly when they might be fearful that their baby may not survive? Think about the benefits of some of the other components in fresh breast milk, such as exosomes and cells. Exosomes, as I said, these are microvesicles packed with proteins, lipids, and nucleic acids, which may be of major advantage. And when we feed breast milk, fresh breast milk, we know that it contains millions of stem cells per mil. So we should aim to give fresh mother's milk once or twice a day following NEC, not just milk that's been frozen. And it may also be true that giving oropharyngeal milk may reduce the risk of oral aversion later on. How else can we improve longer-term brain outcome? Well, surgical considerations. The approach to initial surgery, whether this is a laparotomy or peritoneal drainage, has been explored in the NEST trial. And there was some data here that there was a higher probability that an initial laparotomy reduced the risk of death or neurodevelopmental impairment compared to initial drainage. And a Cochrane review of 3 trials suggested that peritoneal drainage rather than early surgery may increase the risk of severe cerebral palsy. We know that reconnection of the bowel through early surgery may improve nutrition. There are some surgical interventions. So one is called serial transverse enteroplasty procedure, a step procedure. This may improve the digestive absorptive area in the gut and may improve nutrient absorption. And there are newer drugs on the market, so glucagon-like peptide 1 and 2 agonists that seem to increase intestinal growth in short gut. It's also possible that other interventions such as enteral insulin may be potential interventions in the future. Thinking about nutrients and impact in improving long-term brain outcomes, well, as I've said, every micronutrient is important for brain growth. There's good data to make sure we ensure adequate iron intake through early infancy. Iodine is clearly critical, but current NICU practices seem to provide sufficient intakes in most. Babies on prolonged parenteral nutrition may benefit from supplements such as zinc. There are cognitive benefits from breast milk components such as milk fat globule membrane that babies may have been deprived of if they don't receive breast milk. As I've said previously, supplementation with docosahexaenoic acid, arachidonic acid, and choline may be important, but we need more data. And it's possible that macronutrient enhancement after discharge may improve brain outcomes in those with an injury, but again, we need more data. So we need to promote breast milk, we need to avoid malnutrition, and we need to ensure that the diets meet their intake needs, especially for key nutrients such as zinc, iron, iodine, and fatty acids, and continue this throughout childhood. And then other interventions that may improve brain outcome, again, emphasizing the importance of kangaroo mother care, which we know results in better brain outcomes in later childhood. We should see kangaroo mother care as a core component of family integrated care. We need to think about noise and light exposure on the neonatal unit and the impact of sensory, touch, and comfort holding on brain development. And then after discharge, the importance of educational support, occupational therapy, speech and physiotherapy, and the impacts of the home and school environment. And then just finally thinking about the longer term outcomes of the family. NEC creates an enormous stress on parents and the family, both during the acute period and during prolonged hospital stay. The multiple outpatient appointments that these families need can dominate family life. There are impacts on the parents, the costs of being in hospital, their earning potential, their income, their own personal relationships. And it's possible that other needs, the needs of other siblings, may also be adversely affected. Finally, remember, parents never forget their babies who died. The loss of a baby results in lifelong grief, which places a burden both on parents and other siblings. And these families report higher rates of post-traumatic stress disorder. Sadly, around 25% of the infants who die following NEC were actually twins or triplets from a multiple pregnancy. And the loss of your brother or sister may have a lifelong impact on how you perceive your own personal identity, knowing that your brother or sister died as a baby. And we've addressed some of that in our Butterfly project. Now, I've got lots of references, too small to read here, but you can get a copy of these from me if you would like to see them. So I'm just going to finish up here by emphasizing that although we don't know how to prevent necrotizing enterocolitis in many of our babies, there are ways that we can improve their outcomes. We can develop protocols that ensure macronutrient and micronutrient intake needs are met. We can develop guidelines and practices that provide support for mother's own milk. There may be surgical or drug interventions that improve intestinal growth and function. Practices that ensure adequate iron status and thyroid function will also be beneficial, as will interventions that support mothers to continue to provide breast milk. We need to prioritize the importance of kangaroo mother care and the optimization of the sensory environment on the neonatal intensive care unit. And we need to promote policies that enable us to give babies regular, fresh, non-refrigerated mother's own milk so we can maximize the benefit from stem cells and exosomes. And then we need to think about all of the social, psychological, family, and sibling support that these children are going to need over the life course. So I'd like to finish there, and thank you very much for your time.